All right, everyone. Welcome back to the Insights of All Trades podcast. So it's the first time that we're doing a podcast in a while, so I believe this is going to be episode 13 with my dear friend and professor, Dr. Adam VanWert. Before we get into that, Nick, obviously, if you are watching the video, is not with me right now, so he's out in Pittsburgh at med school, and while I'm shooting this intro, I'm not in Wilkes, but where I did this podcast, I was in Wilkes. Right now, I'm actually shooting this intro after the podcast because I'm home for fall break. We don't have any insights right now, so if you could send us your insights. If you listen to episode, I believe it is 11, the recap episode that Nick and I do, we kind of break down this new intro segment idea for insights that we want to do, where instead of sending in things that are kind of broad, sometimes motivational quotes, which is great and all, what we were kind of looking for was insights where you give specific tips that are related to your trade or your passion, maybe like a sport you play, or maybe you're really into cooking, etc. You get the point. And just giving like one little tip that you think everyone in the general population could benefit from knowing that tip. So definitely keep that in the back of your mind moving forward. We would love for you to send us through social media or email any tips that you have. So with that being said, with the podcast that I did with Dr. VanWert, we get into all of the weird expertises that I feel like he has. I've had him as a professor for a bunch of different classes. He knows a lot about the cardiovascular system, about the liver, about the gastrointestinal tract, a lot about pharmacogenomics, which we break down what that means and how it's important to everyone. We get into toxicology, since he's also teaches like a toxicology elective at school, and all of the research that he's done along the way. So he's a really cool guy, and I think you'll really enjoy this podcast. So stay tuned. Welcome to Insights of All Trades podcast with Nick and Cole. This is where we talk with people we meet along our journeys through medicine, military service, sports, education, and beyond. We hope you enjoy. Dr. VanWert, how are you doing?
Good, how are you, Cole?
Not too bad. I'm super glad to have you on here. So for those watching the video, we'll have yet another change of scenery to where we have done the podcast. We're actually in the Hall of Fame room in the Mart Center at Wilkes University, and it's coincidentally where we have our toxicology lecture with Dr. VanWert.
Yep.
So pretty exciting. Had a little bit of trouble tracking down a place to get the podcast set up, and also it's the first time that I set up any of the audio and video stuff myself. So if the audio or video isn't as pristine as it has been from our friend Hunter and Nick setting it up, that is why I'll take the full responsibility.
We'll be okay.
Yeah, I think it will turn out all right. So just to give everyone a background on I guess your expertise, because I feel like there's so many different things you teach. Mm-hmm. Can you give us kind of a walkthrough, I guess, from we'll say pharmacy school up to where you are now, is however detailed you want to get. I know there's
Sure.
a lot of stuff along the way, but just kind of your general path.
As a lot of your peers know, I can talk for a very long time. So give my general path. I was here for 6 years for the PharmD, from 1997 to 2003. And I immediately went to grad school. That's the Medical University of South Carolina for my dissertation, for my PhD. And a lot of people out there don't know that there's a difference between a PharmD and a PhD in pharmacology. And the reality is the PhD is very different because it's all research-based. And if you don't discover something or publish, it's going to be hard to graduate and get your PhD.
Right.
So it's very different. And so a lot of times I tell people that it's a toxicology PhD, but in reality it's, I don't like to really put a label on it because what I studied is much more specific. It's transporters in the kidney and how they eliminate drugs from the body. And that could be pharmacokinetics, that could be pharmacology, could be toxicology if you're talking about a toxin being transported. So the label's not that important, really.
Mm-hmm. Was it during grad school that you had the, I guess I would coin it as a discovery of the I know, like the interaction between, is it probenecid and like beta lactams?
Yeah, I'm surprised anyone even remembers that from class. But yeah, it was something I almost didn't believe it, because you spend so much time in the lab in grad school, and sometimes you don't get any significant results. And then that one result that I got that I'll talk about, I kept repeating it over and over again. It never failed, the experiment. And basically what it was back, I think it was World War II, and my history is not very good, but they were using penicillin in the soldiers for infections. And they found, and I don't know how they discovered this, and a historian would probably know a lot more, but they discovered that the drug probenecid would block the elimination of penicillin from the body.
Mm-hmm. And probenecid's usually used for gout.
Nowadays it's used for gout, which is uric acid crystals, but it's not really a first-line drug for gout, but it is used for that. But back then, they found out, so I don't know how they found out, but they found out that probenecid maintained the residence time, or prolonged the residence time of penicillin in the blood, so they didn't need to give as many doses of penicillin. So for the longest time, they knew that this was in the kidney, that this interaction between probenecid and penicillin to retain penicillin was somehow based on kidney secretion, and blocking the removal of penicillin from the blood, and basically blocking the transport from the blood into the urine. But for the longest time, no one was sure why or how that happened. What, on a molecular basis, on a transporter basis, how did that work? And what we did, unfortunately, I wasn't able to be involved in the very beginning, where they actually made a knockout mouse, meaning they deleted the OAT3, was the organic anion transporter 3 is what it was. And now this is where people might fall asleep. So I'll try to keep a little less detailed. But we deleted the transporter. They deleted the transporter from the embryonic stem cell. That meant these mice were growing up with everything else pretty much normal for a mouse, and they were missing that one gene, meaning they couldn't make the transporter.
Right.
The first question is always, if you delete an entire gene, do the animals even survive? Do they even survive past like birth, or do they even become born? And they did. The litters they call them pups, believe it or not, the mice. They were very small litters, but they would grow. They would proliferate, or proliferate meaning have children.
Yeah.
A very scientific term to say proliferate, but they would have babies, and they would they looked pretty much normal. The mothers were a little aggressive for some reason. I don't know if transport has something to do. Something was building up in their blood that changed their mood or cognitive function or something like that. But for the most part, they looked normal. But what we wanted to do then was see if we administered certain drugs that at this point, we already knew they were substrates for this transporter called OAT3. They did that in very simple experiment, not simple, but non-in vivo, so non-animal experiments, talking about cell lines and frog eggs or xenopus oocytes. They would study transport on this transporter O3, and they found penicillin was transported, and a couple other things were transported. But the thing about that is they didn't really understand in the real live animal, with all these other transporters, all these other elimination routes, does it still matter? Does that transporter OAT3 still matter? But when we deleted it, we found out that when I had to use radioactive penicillin, which is very, very low radioactivity, kind of harmless. It was tritiated penicillin, so it had tritium, which I won't get into more detail on that, but that's a really easy way to measure it. So we injected tritiated penicillin, and I noticed that after about a half hour, the knockout mice had a blood concentration that was 5 times higher than the normal or wild type mice. And then we moved on. That was male mice, and no particular reason why we used male mice, but we moved on to female mice, and the result was even more profound. In fact, actually the result where we found a 5 times difference, that was in female mice, and there was probably 3 times different concentration in male mice. And from that point on, even though it was mice, there's a lot of kind of evidence confirming that transporter is important in humans as well. So that was kind of exciting to discover that.
Yeah. And since then, it's been kind of exploited clinically by giving people, I mean, this is a little bit trickling down the line from that finding, but giving people something that inhibits that transporter, probenecid, with penicillins, which are a type of antibiotic, so that way you don't have to give as much of that antibiotic because it's not getting eliminated from the body as fast.
Absolutely. And they also use probenecid, and I don't know how frequently, but I know it's some clinicians, some physicians will give probenecid to patients taking antivirals like adefovir and cidofovir. They're kidney toxic. If you give probenecid, you can reduce the renal toxicity by blocking transport.
Oh, did not know that.
So that's pretty cool. You can, what else is there? Well, obviously probenecid blocks uric acid transporter. That's why it's used for gout. Mm-hmm. So that's the main therapeutic purpose. But it happens to be a very, we'll say, people use the term promiscuous in that sense that probenecid blocks almost all organic anion transporters. So there's a lot of risk for drug interactions too.
Right. Makes sense. So moving on with that grad school research, where do you go from there? Any postdoc stuff?
I personally did not do a postdoc after 6 years of pharmacy school, 5 years of grad school. I said, well, I think it's time to get a career, and
yeah.
And I was on the fence. I almost worked at the FDA in the Center for Drug Evaluation and Research. They offered me it was called the ORISE Fellowship, where it would be kind of a period where they would evaluate me to see if I would be hired full time. But it was evaluating generic drug applications for bioavailability, and obviously FDA is very prestigious, and I was drawn to that. But I knew that position would have been a lot of repetition, and I'm very not satisfied. Dissatisfied with repetition. So
yeah.
I do teach the same things every year, but I get to modify my lectures. I get to, and that's once a year. So it's enough time that it doesn't feel repetitive that much to me. But then I'm in the lab doing kind of whatever research I want to do, in the meantime. So, yeah, and I also looked at some drug companies, but in the end, I always knew that I liked teaching. I like teaching to my peers. I was a tutor for a long time, in many cases an informal tutor. So I would just, my friends would ask me, maybe sometimes because they didn't study much, or sometimes it was just complicated. They'd come to me and say, can you show me how this works? And it was the best feeling ever just teaching that. So then I knew that I liked teaching. I was more comfortable, to be honest, with one-on-one. And so it took me a little time to get used to the larger group kind of scenario where you're teaching in front of, for us, about 70 students. But I knew that if I could grow to be comfortable in that environment, that I would like teaching. So that's where I am now.
So right out of grad school, there was a spot open within pharmaceutical sciences then here at Wilkes?
I got lucky in that sense. Yeah, there was an opening.
Oh, awesome.
It's very ironic. The professor that was one of our best professors here that I have replaced, Jim Culhane, became a chairman at the College of Notre Dame in Maryland, School of Pharmacy, and the name changed. I can't remember what they changed it to, but it's basically the College of Pharmacy in Maryland. But he's the first person I ever really did research with, and it was quite a different kind of research. We did use animals, but I did research with him here, and then I went off to grad school, and then he left for a higher position as a chairperson. And it turns out that I started teaching the same things that he taught.
So you got to step into the shoes of Jim previous
Culhane,
research professor.
Yeah, and in fact, he wrote a book. I think he's finished with it. He's becoming a very well-known expert in advising students for academic success. And so he's, it's a very intelligent scientist, but also kind of, delving into the other field, which is kind of how do you advise students, and not just informally, but is a very formal process for the way he helps students that are struggling with material. Oh,
so is the audience then of that book, if you know, is it the students themselves how to excel?
I believe it's mostly for professors, educators.
Oh, so the audience is who is advising, the students.
Yes.
Gotcha. Interesting.
Yeah.
So fast forward to where you are now. I don't even know if I could correctly list off all of the classes that you teach.
Sure.
Could you give us the rundown of all the things that you teach
Yeah.
at Wilkes.
It's actually grown since I've been here. My list has grown, but first I'll say that I do teach a lot of diverse things, but as much as there's sometimes stress when I know there's going to be a new topic that I'll be teaching, I also enjoy it because every time I learn, I have to become an expert in something and learn it very well to teach it. Then it helps me with my research in many cases, or at least come up with ideas that I may not go down that path, but at least I have new ideas that I can consider when I learn new things. Become a quote unquote expert in all these different areas.
Yeah.
So I teach all the way at the beginning, anatomy and physiology. And several years ago, we designed it intentionally so that the faculty would be teaching the same organ systems that they teach later on the pharmacology for. So I teach anatomy and physiology of the cardiovascular system, gastrointestinal system, and now it'll be probably the blood as well, which is, some people say cardiovascular, but it's a little separate, blood chemistry and stuff like that. And then that's the P1 year for pharmacy students. P2 year, I'm teaching receptor theory, which I have to be honest, I was inspired very significantly by, again, Dr. Jim Colhane, who I came here to replace when he moved up. He was so passionate about receptor theory that he had me convinced that that's all he thought about all day, and even when he was home. And maybe that wasn't the case, but he's very passionate about it. And so that ended up, I ended up teaching that because he taught that. So receptor theory.
Yeah, just from a student perspective, that caught my attention a lot as a student. As silly as it sounds, a lot of people think of drug receptors as something that is simply turned on, like they're normally off, and then you put something in the body and it turns the receptor on. Or maybe it's something that's normally turned on, you put something in the body and it's turned off. And the exciting thing to me, maybe not for all of my peers that had to study it, was that there was a kind of quantum physics-esque nature to it, in that they're infinitely changing shape. So like all of these receptors and like all of the cells in your body are kind of infinitely changing shape, and some of those shapes quote unquote turn on the signaling transduction pathways in your body. So we kind of chalk that up under the on state, and likewise I'm going to kind of oversimplify here, but say the other half of the time, it's in these shape conformations that are not turning on a signal transduction pathway. And it's really not that simple, but just to visualize something that it's really not black and white, and it's actually infinitely changing. I thought that was really exciting to walk through.
I'm glad you enjoyed it. It's something that when I started here, I really didn't teach that because it wasn't really adopted by the pharmacologists, the prominent pharmacologists. That's pretty much all they're studying. And there's a group of pharmacologists that come up with a nomenclature for different receptor types, and that's not my kind of research really. So I don't get involved in the nomenclature and things like that. But I think we're going to find that's the reality for everything, is that's way more complicated than people that any scientist would originally want to believe it is when they publish about it. It's always revisiting old questions. It's always going to be that way because it makes more sense. You're talking about a very fluid, if you remember the fluid mosaic model for the cell, it's very flexible, very fluid-like. The chances of a receptor being very rigid are probably not very likely that it would not move around, that it would not undergo, that some people would say infinite conformations, like you said, in that some of those conformations are going to be able to trigger some cascade of events inside the cell to activate something or inhibit something.
Yeah, I think it's cool to learn about. Plus, that's where the pharmacy students kind of revisit getting a bunch of different cell receptor types put in front of them. And it's a little bit of forced memorization at first, but through that you get to learn how drugs work by learning what receptors they target.
Yeah, sometimes when I talk to my friends that are toxicologists, I get really excited because they use pharmacology there. And when I say pharmacology, I mean not just pharmacy therapeutics, but mechanisms of drugs. They use it a lot more in toxicology because you don't have a lot of guidelines in that field, because you can't run a clinical trial on a toxin because it's unethical, right? So you have to just use a lot of logic, which not everyone likes to use all the time. But if you use, if you understand how the drugs work, at least you can have a better guess as to what's the best course of action, especially for a combination of toxins that you haven't seen together in someone's body before.
Right.
And that's where you get problems because you have even in clinical trials that are not for toxins, you have patients that will have, they're only in the trial because they met these inclusion criteria and they didn't meet the exclusion criteria. They have so many limitations to who's going to be in that trial. Then when you get a real patient, if you look at them, and I don't have numbers for this, but you look at the patient and say, wait a second, if they were in the trial that I'm using to determine their therapy, they wouldn't have actually been included in the trial, so why am I determining therapy for them based on the trial? So what I'm saying is that it's almost impossible to utilize just clinical evidence when making decisions when you have patients that don't fit into that mold of your trial. You have to use pharmacology.
That makes sense. Sorry I derailed you a little bit there, bringing up receptor theory. So moving on from there, what other classes do you teach at Wilkes?
Yeah, so I teach a lot of things. Also, I teach gastrointestinal pharmacology. I teach, now I'll be teaching infectious disease pharmacology. I teach cardiovascular pharmacology. I was teaching with Dr. Bomerty some of the oncology drugs, but since that's his area of research, I said to him, you do the best justice there to take over that, the mechanisms of the oncology drugs, and that'll allow me to focus more on my newly adopted, we'll call it a module, which is the infectious diseases. In gout, I teach, which is just a little snippet. I got my cameo appearance in one of our courses just to talk about the transporters involved in gout and that kind of thing. And my toxicology elective, and I think that's about everything that I can remember.
Yeah.
That's everything as far as I can
still
remember.
I mean, a hefty amount of courses.
Mm-hmm.
So I kind of want to flip the script a little bit and start trying to tease away information from some of these different pathways that I think people outside of maybe medical practice or or even academia that relates to biomedical research or pharmacological research, things that people have interest in but maybe don't fully understand and appreciate. So one thing I want to talk about is body fat. So we talk about in our cardio module, both in A&P and also kind of revisited lipids in our new cardiovascular PT module. We talked about I don't want to spoil anything, but we talk about cholesterol formation in the body, and also back in A&P triglyceride formation in the body. And I don't think a lot of people understand from the time they consume a food how that becomes the body fat that a bunch of people, whether for aesthetic reasons or other, want to avoid. So how's that process work?
Well, it's probably easiest for me to start with actual fatty acids in your food because they don't really have to undergo much conversion to get to your adipose or fat stores. So basically what happens is when you consume a meal, that if it contains fat, the majority of the fat that you're going to consume is going to be in the triglyceride form, and a lot of people don't realize that. So if you're eating a steak, even if you're vegetarian eating a fat, a lot of times it's in a triglyceride form. So that means I always call it, especially for the older people and the younger people, they know zip files, but they used to be much more common when I was younger. But I call it the zip file, where you have 3 fatty acids bound to 1 glycerol. So you're kind of compacting that, the 3 fatty acids into 1 molecule. And that's how many of your fats are consumed. But the only way they're going to get absorbed is, and a lot of people don't know this, but the stomach really doesn't do very much digestion compared to the small intestine. So what happens is when fat gets in that triglyceride
very
form,
much absorption rather, right?
Yeah, the stomach does
all digestion and no absorption.
It does digestion. It does almost no absorption. But even in the stomach, the digestion is only just the beginning of it.
Okay.
And this is a little derailment of the conversation, but patients that are on proton pump inhibitors that don't have any acid in the stomach, they're not malnourished.
Mm-hmm. So that's things like Prilosec and Protonix.
Correct. Yeah. Right. So back to the idea that triglycerides get into the duodenum. This is the first part. This is the first part of the small intestine. Those fats will not get absorbed unless they're I'll say monomolecularly dispersed.
What's that mean?
And what I mean by that is that you'll have fat globules, and they need to be broken down into individual fatty acids. And not only do the globules need to be broken down, but each globule has just loads and loads of triglycerides, which are, again, the zip files that have 3 fatty acids per glycerol. Those fatty acids have to come off, individually have to come off, and that's done by your pancreatic lipase. But I skipped over something because it was just convenient to kind of go down the path, but we also need bile. The bile, I just call it's like your physiological detergent, right? So if you have fat, grease on a bowl, a plastic bowl that you want to dissolve, you can't do it very well. If you try to rub that with your hand and just water, it just smears it around. You add some dish detergent, right? It's gonna lift off the fat, and that's what your bile acids do. They're actually bile salts. So what'll happen is part of the bile acid is lipophilic. The other part, that means it's oily or oil soluble. The other part is charged, so it has affinity or an attraction for water, and that'll form like a vesicle, or and it'll emulsify the fat. And once the fat breaks apart, it'll keep it small, very small particles. And those small particles are acted upon by the lipase. The lipase is coming from the pancreas. So you need liver activity, so the liver's making the bile. You need pancreas activity. Pancreas is making the lipase, and you also need some movement, so churning of the fat to break it into smaller pieces.
Okay, and our lipase is our physiological scissors, if you will, kind of clipping apart these triglycerides in our small intestine.
It's breaking the free fatty acid off the triglyceride, and once you have that single molecule of fatty acid, that goes into the intestinal cell, in the jejunum mostly, actually. It's the jejunum where you have most absorption.
Which is the second part of the small intestines.
Second part of the small intestine, and then you have... it's strange how the body works, but then it gets generally repackaged into a triglyceride again, and then put into a very much more complicated macromolecule, which is a chylomicron. That chylomicron has protein, cholesterol, and it has triglyceride, and that travels. I think it's phospholipids. That travels very different from most other things. That'll travel to the lymphatic system, which goes into the blood through, the subclavian vein, and that goes right into your systemic circulation. That means it bypasses the liver. Mm-hmm. So I always joke about this in class, and it's not really pathological, but it's a little scary. If you look at someone who ate a high-fat meal and you look at their blood after maybe an hour or two, and you centrifuge it, they'll have a really large fat layer on the top, which is the chylomicrons. And in fact, I've never done this because it's probably a bad idea, but I told a student we should see who can get the highest chylomicron count after going to a buffet or something, or whatever it takes.
Yeah, I'm more than willing to partake in that self-experiment.
Yeah, that's certainly not medical advice.
Yeah, it's AMA.
Yeah, absolutely not.
So maybe just so people can, I guess, appreciate how fat goes straight into the bloodstream, to contrast that with almost any other type of nutritive molecule like sugars and protein that you're consuming, it's going straight to the liver from your small intestine.
That's correct. It goes all through the portal vein, right to the liver capillaries, which are the sinusoids. And then the liver has first dibs on what it wants to do. It can store the glucose, it can take a drug and metabolize it, and then it'll put it right back into the gastrointestinal system, or send it, or let it continue and go into the systemic circulation, to the inferior vena cava, through the heart, and then the rest of the body.
Right. So moving forward a little bit with the fats, a lot of people hear things tossed around about cholesterol, and everyone thinks of cholesterol as evil. And there's some, grounded reason for people to have that belief, and they hear about LDL being bad and HDL being good, but if you ask the common person, they might not know why they're bad and good, and they might not know what cholesterol in general is doing. Can you kind of give an overview of cholesterol?
I could give an overview, definitely, and I'll say the caveat or warning that I have is that There's always new research coming out, and some people are claiming that LDL is not really a bad thing, and I think most of the experts still would agree that it is to have high LDL. But I'll get into what you asked, which is what is cholesterol, or why does the body use cholesterol? Cholesterol is used for a lot more than the negative things, and some people don't think of this first. The first thing I think of is steroid synthesis. All your steroids, that means testosterone, estrogen, progesterones, or any other molecule that has that steroid backbone, they require cholesterol. And if anyone goes online on any common Wikipedia or somewhere else, you'll find or PubChem, if you type in cholesterol and then you type in any one of those steroids, you'll look at it. They almost look the exact same. Even if you don't know organic chemistry, the structure looks pretty much almost the exact same, very similar. So without cholesterol, if somehow you could just remove it from your entire body, you would not survive. You wouldn't have steroids. And again, some of the other things are cell membrane rigidity. So membrane rigidity is determined by cholesterol content, and that's way back to biochem years, and I don't remember exactly how much, what amount of cholesterol adds high rigidity versus low rigidity. I don't remember, but you need to have cholesterol in there. Cholesterol is also used to make the bile acids. So that's kind of ironic sometimes if you think about it deeply enough, you think how ironic it is that the cholesterol is being modified into a salt or an acid that can then help you absorb triglyceride. So one lipid is being modified to pull in a different kind of lipid. So it helps you emulsify the triglyceride. So it's kind of interesting how the body does that.
Yeah, so clearly there's some physiological importance of cholesterol, but to paint the picture a little more fully, what are the bad things then that could go wrong that cholesterol is associated with?
Yeah, and I'll be the first to say I'm not an expert on this whole idea of lipid deposition, but let me just get into it. Basically, the idea is that LDL, which is low density lipoprotein, and it's only named that because you have a lot of different things called lipoproteins, which are made up of lipids, so cholesterol, cholesterol esters, and phospholipids and proteins and things like that. There's a lot of different kinds, and if you measure their density, they all have different density, and some of the lowest density would be LDL, low density lipoprotein. Most people call that cholesterol, bad cholesterol, but like I said, cholesterol is just a lipid type of molecule that has a steroid structure. There's cholesterol, again, in the LDL, there's cholesterol, there's protein, and there's phospholipids, and some triglyceride, not a lot. So actually, there's a lot of triglyceride in the LDL. So it's not just, LDL is not just cholesterol. Cholesterol is part of that. But when people say bad cholesterol, they mean cholesterol, again, that's in the LDL, generally in the LDL particle. And one of the biggest problems is, and again, this is not, I wouldn't say 100% of experts agree that LDL is bad now, but there's some evidence that LDL deposits, definitely can deposit under the subendothelial, into the subendothelial space, which is, if you look at this, any video or advertisement about lowering lipids, they usually show all the cholesterol in the center of a blood vessel. The reality is it's under the wall of the blood vessel. It's under, so we have these, so if this is a blood vessel, it's lined by endothelial cells. That's a single layer of cells. The cholesterol's under that, but that cholesterol is deposited by the LDL. And there's strong evidence to support the idea that basically when the LDL gets oxidized by some inflammatory process, it gets engulfed or swallowed by macrophages, which are defense cells.
Which are a type of white blood cell.
White blood cell. They can die, and sometimes, and those are called foam cells. I think because of the appearance, they call them foam cells. And when those accumulate, then you have atherosclerosis, and you have the wall getting thicker and thicker, and eventually, rather than being smooth, it has a bulge, and that can rupture. Right, and then you can get a clot.
Just as a quick recap then, so the LDL, again, kind of for simplicity, drops off cholesterol underneath the, we'll just say into the wall of the
Sure.
of the blood vessels, and they can remain there often because there's types of white blood cells that take them up and die. So now you have these like plaques over time forming up large, if this theory I guess is correct, largely due to this cholesterol drop off from the LDL. And when you get that plaque buildup for maybe I'm not wording this perfectly, but it's going to be narrowing the blood vessel, so you're going to have higher and higher pressure in that blood vessel and make it more and more likely to rupture. Plus, it's that kind of rigid plaque doesn't have as much plasticity, I guess, as the normal blood vessel.
Absolutely. So if a tissue has impaired blood supply or low oxygen, normally the preceding arteriole would dilate. If you're loading that with something rigid like this cholesterol plaque, it can end up having a poor ability to dilate and then to provide that oxygen. So that's definitely a problem. One of the other problems is when it bulges out rather than being a smooth surface and you have a bump, there's some experts believe that turbulence of the blood, and you could hear that if you had a very sensitive kind of microphone, put it there, you can hear the turbulence. And when that turbulence happens, it's thought to cause like a shear stress on the endothelial cells. And I imagine that alone wouldn't be enough, and that's just as an assumption. But I imagine that combined with the inflammation there is what's going to cause rupture. Once the endothelium ruptures, that's when you get a clot.
Right. So there's, I guess, a brief synopsis of LDL. So on the other side then of what people think of as good cholesterol is HDL. So what does HDL do then that made people think of that as a good cholesterol?
So from my fairly thorough reading actually on in several different cardiology books and journal articles, and by the way, one of my favorite places to look for any information on an entire disease process would be Nature Reviews. The images are awesome. So, and I don't recall if I got this information from one of those, but that's a place that I generally try to look to first.
Do you have like a website and a journal, or is it just like a website?
I'm not sure. I mean, I normally just go I'll go to like PubMed or something, and then I'll look for review articles, and usually Nature Reviews will pop up pretty fast.
Oh, okay. So it's usually just review articles they're pumping out. So it's like a journal then. Well,
the journal Nature started off as one journal, and now there's so many journals.
Okay, so it's like a sub journal of.
They have hundreds of sub journals now. They have a lot of sub journals now.
Okay.
And one of my favorites is Nature Reviews because they have really crisp images that are not overly complicated, but they're accurate, and so I use those quite often. And Nature is one of the best journals in the world, so you can rely on that for the the accuracy and everything.
Yeah. And not to totally derail us, but just a quick tidbit to throw in for everyone. PubMed is something that is available for everyone for free if you just like go in and type in a quick Google search. So it says there's no barrier to entry here for digging a little bit deeper if that's something that you're interested in.
Right, and you could read most of the abstracts, and sometimes if you want to get a full article, sometimes you'll find them on PubMed Central, which is all free, or you can generally get them at a library through interlibrary loan if you can't find them full text immediately. So if you're really craving to get more than just the summary, like I usually am, I want to see the full text. So
right. Sorry, wanted to put that out there for anyone wanting to learn more. But back to HDL.
So HDL is a lot more complicated than a lot of people want to think, I believe, because the HDL that is measured in the labs is high density, and it's the mature HDL. So mature HDL is HDL that is already loaded with cholesterol, and what I mean by that, even though HDL is considered a good fat, it's another lipoprotein, so it's more complicated than just fat. It has protein in it and other things, but that HDL is already matured, and what I'm much more interested in in terms of therapeutics and disease, a prediction of someone's disease prognosis and that kind of thing, and their lifespan is looking at your synthesis of pre-beta 1 HDL, and what that is it's the premature HDL. And the best way I could explain that to make the most sense of it is just your regular HDL particle, which is a sphere in a sense, but it's hollow. It has no cholesterol in it. So it is primed and ready to bring in new cholesterol from the wall, under the wall of the blood vessel. So I know there are some groups out there that are looking at synthesizing this HDL, this pre-beta 1 HDL, either completely synthetic from nanostructures or trying to actually produce real premature HDL in a lab and then injecting it. And I so far haven't seen a lot of clinical trials on it, so I don't know what the results. I really haven't seen any outcomes yet.
Was there any clinical trials started up at all that you know of? Were they
actually? I think it was all preclinical at this point. I think it was all animal studies, and I don't know that any of them have. It's partly me not having the time to look up the results, so I don't know what the results were yet at this point. If any of them are conclusive at this point.
Oh man,
but
sign me up
it's
for
exciting.
Yeah,
I want to get a dose of that.
Yeah, for the phase 1 where they take in the healthy patients, track one down, see if I can get some synthetic HDL.
I would love that. Yeah. So what happens is, the mechanism is that HDL has been shown to travel to the blood vessel wall, and there's a transporter, believe it or not, called I think might be ABCA1, but there's a transporter that's on the macrophages that are there, and some of them are still alive and everything, they're functioning. But when the macrophages accumulate cholesterol from the LDL, some of them that are still functioning, still alive, have been shown to transport through this transport cholesterol into the HDL, the premature HDL particle, and fill it up.
Which would be good because then you're getting it back out of the wall of the blood vessel.
Right, so that's the idea, to get as much out of the wall as you can. And unfortunately for the liver, that's the dump site. So generally it's very complicated actually how it works. The HDL doesn't generally go directly to the liver. A lot of times the HDL particle, when it's filled with cholesterol, he has friends in low places in a sense, or he has some kind of bad guys, because he sends that HDL particle can send cholesterol to LDL and exchange that for triglyceride. And there's evidence that when that happens, and that some of that LDL will go to the liver, deposit the cholesterol, and that'll get eliminated. You could get cholesterol in the bile, or it can get converted to a bile salt and then get eliminated. So, and then through the fecal route, right? So, the number 2 route.
Yeah, the number 2 route. Now for another caveat with cholesterol that I think definitely is not appreciated enough, is that when people think of cholesterol, they rightfully associate it with fat. But we know that it's not just dietary fat that can become cholesterol. So I think you kind of know where I'm tiptoeing this too.
Yeah.
But we know there's other things that can become cholesterol.
Yeah, one of the things that annoys me as a consumer is when I see that something is listed as fat-free, and a cholesterol is a lipid. It's not really a fatty acid at all, but it's a lipid. But when I see something listed as fat-free, like gummy bears or anything
high
sugary,
sugar thing,
sugary stuff, right? High sugar, no fat. The problem is, a lot of people might believe that it's not going to contribute to my cholesterol, and that's completely wrong. And unfortunately, I think the companies that are doing that, they don't have enough pressure to be honest, and they're not lying, but they're also not giving the full information, which would be, this can get converted. So glucose gets very easily converted into cholesterol. Okay, so sugar gets converted into cholesterol. So you can get cholesterol from sugar, from cholesterol in your food, or even fatty acids can get converted into cholesterol. The body's very good at breaking down larger molecules and making whatever it wants out of them. Okay, so and unfortunately, we've evolved for the most part in a situation where we're starving, or we have a high risk of not having access to food for several days. When you think millions of years ago, or even hundreds of thousands of years ago, when we didn't have access to food on a regular basis, our bodies are designed to absorb 100% of what we consume. Okay, so even if we don't need it, our bodies will find a place in our body to put something.
Mm-hmm. And you were just telling me the other day how you didn't think we would kind of evolve away from that, since you could do a better job explaining it than me, but we usually have our human progeny well before we're having like these disease manifestations because of overconsumption of food.
Right, so the central idea of evolution is that one of them at least, is that you do not deselect for something detrimental if that does not kill you before you proliferate, right? Or, if it's late in your life, after you would have already had children, you would have already passed on the bad gene. So if you die after that, the gene is already, someone already has it.
Yeah.
Your poor children have taken that gene.
Yeah.
Right. So that's the crux of that. That's the main idea. So you may, if cardiovascular disease happens later in life, which it does, right? So 60, 70, 80 years old or older, most people would have already, especially women, right? They have no choice. If they're going to have children, they're going to have them in, 40s or earlier, right? And men, they can do it, but it's not as common to have children when you're, 70 and stuff like that. So they can, right? But you're talking your chances of passing on a gene that affects you later in life, right? You're going to pass it on if you have children. It's a definite.
Makes sense. So speaking of genes, that kind of gives us another segue into another one of your specialties that I wanted to bring up, and that is pharmacogenomics. And actually, off the top of my head, I don't know if we brought that up at all and are talking about the many classes that you teach and
I forgot to mention that.
Kind of specialties that you have. But pharmacogenomics is something that I think applies to so many people, but if I were to put it out there in the streets, most people wouldn't know what I'm talking about.
Right.
So can you tell me a little bit about what pharmacogenomics is and how it applies to the overall population?
It's actually not as complicated as it might sound. Actually, pharmaco anything usually sounds more complicated than it needs to be. Let's get pharmaco-educated, I guess. Just kidding. So pharmacogenomics is basically, if you've ever had a relative, me when I was a pharmacy student, I had relatives or friends say to me, how come, my friend and I take the same amount of this medication, we're the same weight, the same gender or sex, we have different results. And the question is why? And all I could say for most of my life was, just personal differences. Maybe genetic. Maybe it's genetics. I'd say maybe. Who knows? But now we know for a fact it's genetics. Okay, so we're just scratching the surface of it. So why do some people respond in a toxic way to the same dose of a drug that someone else responds in a healthy or safe way to? And that's simply because from when a drug enters your body to the time it leaves, it interacts with so many proteins that are different in everybody, and that's because the genes that produce those or encode those proteins are different. So some people have more of a gene that breaks down a drug, some people have less of the gene, or they'll have the gene, I shouldn't say less of the gene, but less of the protein that's encoded by the gene. So for instance, if two people have a drug that goes to the liver, but only one of them can metabolize it because only one of them has the gene that allows for that, then that other person will have a much longer residence time of that drug in the body that doesn't break it down, and then they'll have a higher risk of toxicity. So that's pretty simple. I mean, in a sense, it's just the things that you normally see. Hair color is different, eye color is different. There's no reason, and that's all genetically based. There's no reason why that shouldn't happen for things that we don't normally see, which is enzymes and transporters and things like that. And that's the case. Those are very highly variable in terms of their phenotype as well.
Yeah, so we kind of alluded to those enzymes you can have, we'll say, just termed phenotypically, rapid metabolizers of some drugs or poor metabolizers of some drugs. And to put that into perspective, this affects a lot of common drugs. So one of the things that I guess caught my attention with how negatively someone's genetics could affect their response to drug therapy is when we were first introduced to this, we were talking about it's a liver enzyme called CYP2D6, and it metabolizes codeine into morphine. So that's kind of another sidebar. Maybe people don't realize that if they ever had a prescription for codeine, or at least in Pennsylvania it's a prescription. I don't even think it's prescription everywhere, but codeine gets converted into morphine in your body, and it is morphine that's bringing about those pain relieving effects.
Yes.
So with this liver enzyme called CYP2D6, you can have people because of their genetics being like rapid metabolizers. And if you're someone that has that phenotype, meaning the genotype that causes that expression of fast metabolizing of codeine, you can build up toxic concentrations of morphine while taking, not really that high amounts, possibly therapeutic amounts of codeine, or what we're told is therapeutic amounts of codeine. And I don't know if people realize how many possible drugs are directly affected by pharmacogenetics. Off the top of your head, do you know like what we'll say mainstream drugs people are taking that maybe they should look into their genotype?
That's a very helpful question. Yeah, that's very practical. So I'll just give some off the cuff. We know clopidogrel or Plavix is affected by CYP2C19, one of the enzymes that, interestingly, that if you have poor metabolism with that enzyme, you have low effectiveness. So the clopidogrel will not prevent blood clotting very well.
Yeah, and I mean, people are starting that drug often because they had like some sort of cardiovascular disease related thing, like say a clot. So that would obviously be very problematic for them if because of their genetics they can't activate that drug in their body, and then they continue to get clots.
Right. So that's an example where there's direct clinical evidence that it's dangerous to use that drug if someone has that CYP2C19 mutation where they can't metabolize the drug. There's so many antipsychotic drugs, and I can't think of a lot of their names right now that rely on this one that you mentioned, CYP2D6. I always is one of my favorite examples, which is simvastatin, because I study transporters for my research, and it's well known now that simvastatin, if you have the SLCO1B1 mutation, which is OP2, it's a transporter in the liver, hepatocytes, the liver cells, and it's exposed to the blood. It's on that side of the liver cell. That if that transporter is mutated and is not functioning very well, the simvastatin will accumulate in the blood to an abnormally high concentration. And you'll have a higher risk of toxicity, and one of those is muscle pain. And I believe the study that I usually use says there's about a 20% chance of getting that myopathy or muscle pain if you can't transport that, if you have that mutation. And normally it's less than 5%, maybe, 1 or 2%, something like that, the chance of getting that toxicity. What a lot of people probably don't think about is that for some of these drugs, their target might be also affected by that mutation. That means, what I mean by that is that for simvastatin, it has to work in the hepatocyte for it to be effective. It blocks cholesterol synthesis there. So if you're blocking transport into the hepatocyte, you would expect the drug to not be that effective and to accumulate in the blood and maybe be toxic. And there's some evidence to support that. Some trials, that's the only statin where they've proven, at least one trial showed that actually does take place, that the efficacy or effectiveness is lowered by mutation.
Right. I actually had a pharmacogenetic question that I'm hoping research answers soon, and mainly because of the advent of a bunch of legalization of this, and it's cannabis. And I'll tell, I think it's a funny story, but it's necessary that I give kind of a legal preface for this. So I have a friend who, under legal conditions in a legal state, and who also is not a Wilkes University pharmacy student, or even a Wilkes student for that matter, had, again, in a legal state, had both smoked cannabis and consumed it orally, meaning like they digested it by mouth, and they had no, I'll say, what they called like adverse psychiatric effects, which was really just like, from what I understand, extreme paranoia and whatnot from the smoking, which we know doesn't go through the liver because you're not swallowing it, which is where you have the bulk of all these metabolic enzymes. But when he consumed the edible formulation of it, and it goes through that first pass metabolism and it hits all the liver, he had like borderline hallucinations from this substance that's not supposed to be hallucinogenic at all, and he hated it. And my my pharmacy student hat was on, and I was thinking, I wonder if there's some sort of pharmacogenetic expression that he has, meaning like I wonder if there's any sort of metabolizing enzyme that he has, because I know from the little bit of research that I try to do on my own, the molecule that we associate with cannabis that gets people quote unquote high, the psychotropic effects, are from THC when you inhale it. But when you consume it orally, it's not nearly as much THC. THC gets hydroxylated, meaning a metabolic reaction where an OH group, meaning an oxygen and a hydrogen, get kind of stuck on the THC molecule, which supposedly has a lot more, potency, quote unquote potency, meaning a much higher affinity for the those drug targets that it has in our body. And I thought maybe he has like an increased expression of whatever that metabolizing enzyme is, where he's like just pumping out crazy amounts, like much faster amounts of that.
And there's a chance, that is the same as one of the drug metabolizing enzymes, because you might remember this, that the enzymes that hydroxylate are generally in the cytochrome P4, it's usually cytochrome P450 system. Those are oxidative enzymes. So that might be the place to look. Again, cytochrome P450 has just a slew of enzymes. It's a whole system of enzymes, but their primary function is to oxidize, so oxidative. So they're not reductive, and they don't conjugate like the phase 2 metabolism enzymes. So that's where I would start. And maybe you could look at some drugs that have a similar structure to that, to THC, and see, or maybe they know. Maybe is it already known what enzyme metabolizes THC?
Yeah,
maybe
I would imagine, but I don't know what it is.
I'm not sure.
The top of my head, but to look at like different ways it can be expressed, or like among the population, if there's kind of different phenotypes that's seen.
It's very complicated because an alternative hypothesis is that the target, and I noticed when you mentioned the drug target or the target for THC, you didn't mention a drug or a receptor name, and that's because I actually think it's not very well known. We do have CBD receptors, or I think they're CD receptors. I can't remember, but we have.
I think it's like CB1 and CB2.
We do have those receptors, but
and then there's a bunch of other ones.
Those aren't believed to be as far as I know, the ones that produce that high.
Yeah.
So it's not very well known which are the most important ones. I don't think it's well known.
Yeah, I looked much, aside from that single thing happening causing me to research it more, I looked a lot more into CBD's pharmacology, especially since more patients in a community setting asked me about that.
Right.
And just speaking for CBD, it does bind like the CB1 and the CB2 receptors in our body, but it also binds like serotonin receptors like 5-HTA, and it binds a whirlwind of other receptors that are slipping my mind, but I would say 8 to 10 known receptors that it's either an agonist or antagonist at.
So which ones are actually producing that? And some people consider it a detrimental effect. Some people consider it a desirable effect, right? From THC, depending on the person.
Yeah.
Right, but that's, I don't know what I was going to say.
No worries.
I don't know what I was going to say.
I do kind of want to keep talking about things that, we got into this path by talking about pharmacogenomics, but then a lot of what pharmacogenomics pertains to is liver metabolizing enzymes. And another one of your specialties, if you will, is toxicology. And a lot of drugs that are toxic because they're toxic to the liver. And I don't want to kind of unveil this for everyone because you'll do a better job at it, but people probably don't realize what drug is most commonly overdosed upon, at least in the U.S. Can you walk us through what that...
Yeah, this is one of the easiest questions you could ask me because it's just so prominent. So what you're referring to is acetaminophen or Tylenol. Acetaminophen is the number one cause of acute liver failure. Okay, acute liver failure is rapid onset. It's not over time, over many years. So that would be alcoholism, some people hepatitis, but acute liver failure is much more rapid. Several days, generally less than a week. And I don't know the actual clinical toxicologist might have a very specific timeline, but it's very, very rapid. But that acetaminophen is really one of the most toxic. Let me clarify, it's one of the safest drugs if you take it at the correct dose. If you overdose, it's one of the more toxic drugs to the liver.
What I know that we're taught in class, the maximum dose not to exceed is usually 4 grams per day. What dose is it, like roughly, that someone would have to consume then to have like the acute liver failure?
Yeah, depending on where you look, some people are more conservative, but for the most of my career, it was 10 grams. Some people might list 7.5 grams per day. So if you had, we'll just say 10, if you had 10 grams or more in one episode, one dose, again, if it's just immediately at one time or within a few hours, 10 grams, you at that point there's a very obvious, very significant risk of liver damage. Okay, so as you know, the liver damage is not rapid. It's not rapid compared to some other chemicals, so it's going to take several hours.
Yeah, and one of the implications of that we discussed a little bit in our toxicology lecture is that in the unfortunate event that there's a patient with some suicidal ideations and they intentionally consume a bunch of like Tylenol because they just see pills in their cupboard and they make that decision, but they don't exactly know how it works. They just associate taking a lot of pills with achieving, in this case, the goal of suicide. And maybe they take a whole bottle's worth and have the revelation that they wish they hadn't done that, and it turns out they're quote-unquote okay a few hours from then, but then they, they aren't actually okay because it takes so long afterwards to actually see the acute liver effects.
In fact, a lot of the overdoses of acetaminophen are not suicidal, but for the ones that are, that's the unfortunate situation. You normally kind of think that, well, it's nice to have, and it is nice to have a window of time that you don't immediately have toxicity when you take acetaminophen. But if someone did overdose and then they decide that was a mistake, and if they feel fine after literally at least 8 hours, you'll probably feel fine. Some people get some symptoms that are very flu-like and very nonspecific, but generally feel fine. And then you might think, well, you don't have to go to the hospital, you don't have to call the poison center, you don't even have to tell anybody, you're fine. And little do they know that, again, within a window about 8 to 12 hours, you'll start to get real liver damage. Okay, and that's before that, almost no one will get serious liver damage. So it's very delayed and very consistent. And if they knew enough about it, then go to the hospital ahead of time, or get treatment whatever venue they need to get treatment at, and they get the antidote, which is actually 100% protective if they get it early enough.
Which is N-acetylcysteine,
which is also called mucomist. That's been used to loosen up phlegm and things like that, and loosen up the mucus in the bronchioles. That's kind of its secondary or other role, but its main role, at least from our perspective, is an antidote to acetaminophen poisoning. And
a lot of people actually will buy like N-acetylcysteine over the counter as a supplement because there's some research that suggests it's kind of just liver protective.
There's a lot of experts that believe that it's actually a good idea to have some N-acetylcysteine on a daily basis, because it is, and I apologize to the non-chemist, but it is a thiol. That means it has a sulfur and a hydrogen, an SH. And a lot of the toxins that enter your body, they end up binding to your thiols in your cells, and in the proteins on your cells, which would be in your cysteine amino acids. So rather than binding to your proteins, if you give a cysteine which has the SH on, or the thiol, that will the toxins will instead bind to that, and that's one of your most protective mechanisms is this thiol kind of chemistry. And if you give N-acetylcysteine, some of that will actually be utilized and converted to one of your most common protective peptides, which is called glutathione, and that's a tripeptide, and it has cysteine in it. And again, I don't know that there were any clinical trials on N-acetylcysteine. It's known as, it's one of the safest in terms of an antidote. No one's going to ever have toxicity from it. Mm-hmm. So I would never consider it harmful, with the caveat that if you get it from a non-regulated source, you don't know what's really in it, right? It could be anything in there.
Yeah.
There could be none of it in there. So that's the thing, is you want to make sure you're getting it from a reliable source, and that's not easy to do.
Yeah, especially with the U.S. supplement industry, where there's no direct regulation by the FDA. They're kind of innocent until proven guilty, meaning they don't have to go through any sort of process to get put on the market. They get put on the market, and then if the FDA finds any problems with them, then they can be taken off the shelf. So word to the wise, be very careful with the supplements that you choose. Make sure it's a I wouldn't say a well-known brand, but at least something that's trustworthy, a company that you trust.
Yeah. If you find that it's FDA approved, or they use, what do you call it, the USP standards.
Yeah.
United
I know
States
some of them say like
standards.
GMP, like the good manufacturing.
Good manufacturing practices, that would be more reliable.
Mm-hmm.
I would trust them more than a kind of random company.
Yeah, I agree. So we did get to talk about Tylenol some, and I like bringing that one up because it probably catches some people off guard about the vast number of overdoses that happen with Tylenol. And to flip the script to something that's probably more commonly associated with liver toxicity is alcohol.
Mm-hmm.
And people will kind of regurgitate, like, yeah, I know that alcohol is bad for my liver, but maybe they don't know why. Could you also bring that up as well? Like, what is it when people consume excess amounts of alcohol that damage their body, which we know is mostly the liver?
That's actually still being debated as to what. So when you consume alcohol, which is the less toxic alcohol, the one that we're used to drinking, if you drink, is ethanol, even though that's toxic as well. But the other alcohols are more toxic. But ethanol is metabolized into acetaldehyde, and then that's metabolized into acetic acid, which is what's in vinegar. But there's some evidence indicating that it's the acetaldehyde might be what's causing the toxicity directly to the hepatocytes in the liver. And that molecular mechanism of toxicity doesn't seem to be very well understood. We do know something I talked about in our toxicology class. We do know that there's a cell type in the liver called the stellate cells that are between the blood and the liver cells. So they're in the middle. They're called the interstitium. Those stellate cells are responsible for producing what seems to be the majority of the scar tissue, or collagen, which is the same thing basically. The collagen builds up, and that's the problem with alcoholism. Is once you cause enough damage, you literally get scar tissue, and that doesn't seem to be produced very effectively, that scar tissue, without those stellate cells. And so that's an area of research that people are looking at. If we can block the stellate cell function, it might promote more drinking, but
yeah,
it may save some people, maybe. At least you wouldn't have the scar tissue as much.
Mm-hmm.
Now, whether or not, of course, you still might have hepatocyte damage. But in fact, one of the biggest problems, though, with cirrhosis or from alcoholism is, the liver cells being damaged is bad. But one of the worst reasons, one of the biggest reasons why that's a problem, is that you have impaired blood flow. When the scar tissue builds up, blood could not flow through the blood vessels in the liver, which are the sinusoids, or the little capillaries. They get blocked by the scar tissue. Blood backs up, and if you know the anatomy, you know it backs up into a lot of your gastrointestinal organs. Okay, it backs up into the portal vein, and then the capillaries, mesenteric capillaries, and then back into, actually a lot of other veins, I should say, as well.
Yeah, so all of the blood vessels flowing from things like your stomach and small intestines, and I don't know how much vasculature comes from the esophagus. I'm guessing a decent amount.
It has to be, because the esophagus is that's why people generally would die from cirrhosis, is bleeding from the esophagus.
Because the blood backs up, and then the blood vessels burst in the esophagus.
Correct. You get a lot of us have seen varicose veins in legs, and in many cases,
which are just quote unquote leaky veins, right?
Yeah, the veins are. They're not. The blood is not only moving forward; it can backtrack a little bit. Mm-hmm. They swell up. In a lot of cases, it's benign, not really harmful. But if you get the varicosities or varicose veins in the esophagus, if they get enough pressure and they rupture, it's severe bleeding at that point. And you're talking the number one cause of death from cirrhosis is not just the liver, not really the liver cell death, it's the bleeding, usually the esophagus.
So when it bursts, they'll quite literally internally bleed like into their esophagus.
Right.
Sad. So there's I guess the issue with chronic alcoholism. Is there anything that happens differently, I guess, with like an acute spike in alcohol intake, like say someone just binge drinks on the weekend a single time? Is there any direct liver or other organ damage that person should be worrying about?
I know the kidney, a lot of people don't think about this, the kidney is an organ that's sensitive to excess alcohol. And it's not that common, there are reports of kidney failure from binge drinking alcohol. Again, it's not that common. So most people that binge drink, the biggest organ that's going to be toxic is going to be the central nervous system, right? Lose cognitive function and maybe aspirate their own vomit, right? Their regurgitation, and that's the typical horror story you get when you're maybe in high school.
Yeah, wasn't it the lead singer of AC/DC? Is it? I'm gonna look like a ding dong if I forget this on the podcast. I think it's Bon Scott. Was that his name? The lead singer of AC/DC that like.
I don't know.
Had like literally drowned in his own vomit. It's whoever was like the initial lead singer of AC/DC, and then he was.
That embarrasses me too because I should know that.
Yeah.
Sorry,
everyone.
I just don't remember. Maybe you're right. You're probably right. Let's go with that.
Yeah. Anyway, so there's some physiological.
I love their music though.
Yeah.
Lifting weights. You know?
Yeah. I was saving this question in the back of my mind for the end, but I'll bring it up now. You said in class you had a good band name saved up. That if you ever made a band, what was the name of that?
Well, it's called shockwave lithotripsy, and that's because, that's what they use to break up kidney stones. It's the sound waves focused towards the kidney, but I just thought it sounded like the most, if you want to think of a scary, kind of like tough name, shockwave lithotripsy. Right?
So that's how they focus that sound waves on, I guess, your kidneys when you have kidney stones, but technically I guess you could be getting some shockwave lithotripsy when you're just in front of an enormous speaker at a concert.
And I was joking about that, but it wouldn't surprise me because your kidneys are not that deep. They're obviously they're in the back to some extent, but you'd get some vibration. Yeah. You never know. I wouldn't use that therapeutically.
Yeah, I don't think the nephrologist is recommending people go
no, because
get their kidney stones at concerts.
If you're not monitoring it, then you might end up dislodging something and blocking something else, and blocking something further down the road, further down the path of flow.
Right. What kind of music is a shockwave lithotripsy going to play? Sounds like a Zeppelin band.
It's heavy metal. No, it's heavy metal. It's like the Octane station on
Sirius.
Or it wasn't really by choice. I grew up with heavy metal in the household because my brother,
really?
he's a really good guitarist, but he started me off on Megadeth and Metallica.
Oh man!
And I still like their old music though, probably their best. Before they cut their hair off, Metallica.
Oh yeah. We were listening to your brother in class the one lecture. I don't know if it was you that first showed us your brother or if it was Dr. Calusi, though.
Yeah, Dr. Calusi did the one time. That was unexpected to some extent. Well, no, he asked me beforehand, but I didn't expect him to ask me that. So, my brother, it's funny because I tell him this all the time. He's one of the smartest people I know. He's probably smarter than I am, but so he chose instead of the science route, and basically he's chosen the creative artistic route, which actually happens to involve a lot of math and science because he programmed a cell phone app and a website for training guitarists in sensing errors that they're making in their picking technique. Yeah. So he's very mathematically and scientifically minded, even though he's an artist.
Yeah.
So it kind of runs in the family. It came from my father, really.
Was he a guitarist as well?
He was a guitarist. He played the steel guitar and he sang in a band. My grandfather on my mother's side was a guitarist, and my father's brother, so then on the father's side, he was a guitarist. So I didn't get that gene apparently.
I'm actually in a really similar spot. My grandfather was in a band that like at least locally was very well known and would like play on our radio stations and whatnot. My dad as well is very well known in our area for putting out music, and my sister, who's a couple years younger than me, she's very musically inclined, I guess, not just with guitar, but I mean she'll play like guitar at our local winery, but she'll also play piano. She'll play piano and sing in the worship at our church at Cedar Grove. She plays like ukulele. She plays a bunch of different stuff. I don't think if there's any genetics associated with it, I did not get those genes.
I've tried to learn guitar, and I feel like it's a thick wall to break through before you make real progress, and I couldn't break through it.
Yeah.
Ran out of time, I guess, and I just gave up.
Yeah. I got a Fender guitar for, I think it was like Christmas when I was maybe 12 or 13. I kind of did want to learn, but I think more so I just wanted to humor my dad. Maybe not humor him, but make him feel happy that he's kind of passing on like the music thing.
Sure.
I feel like I really just could not stick it out.
Yeah, that's my brother did enough of that, kind of doing what my dad, being the musician. So I didn't have to pick that up because at least we had one person doing that in the family. And in fact, my father he carved a guitar because my father likes to do woodwork and electronics and things like that. But he carved a guitar for my brother, electric guitar, out of I think it was a hardwood, and he polished it for a month, sanded it. He worked on it for so long to get it perfect, and my brother said that's the best sounding guitar he's used.
Wow.
And here I am saying, if it's an electric guitar, why does the shape matter? And I still don't know, but
yeah, so. I could not tell you. Anyway, I do have one last, I guess I'll just call it big segment that I wanted to turn us to, and it's just academia in general. So I didn't know if there's any big shifts that you've seen, for better or for worse, since you've been a professor, or even if you want to tie in since you were a student back in, you said 97 was when you graduated, right?
High school, yeah.
So I guess any big shifts you've seen in academia since then in the past roughly 20 years?
Yeah, I don't want to be the person that says that, because a lot of people say, well, students they feel entitled, and I hear that all the time. I don't know that that's the case. I've had classes of students that were, had really good critical thinking and really in depth, and then I've had classes of students, and really it's variable. So one group of students, maybe you'll have 20 that are real good critical thinkers. You'll have the rest that just say, well, what's on the test and things like that. So I don't know that it's that different. Something I haven't really spent a lot of time thinking of. I've thought about it, but not really in preparation for this discussion. But trying to think of off the cuff, what do I notice that's different?
Maybe I'll give you some things from the student side that I was wondering if affected you, and fortunately for what I'm about to say, pharmacy is a little isolated and might not experience some big societal shifts that you might see in the social sciences, and how I'm guessing being a professor and those things would be affected. So for example, I was listening to and reading some of Jonathan Haidt's stuff. So he's a clinical psychologist by trade, but has also wrote books like The Happiness Hypothesis and, more important to this conversation, Coddling of the American Mind. And in that, he talks about the shifts in, I'll call it, a combination of forcing people to only and always be politically correct, and also this call-out culture that we have where people kind of gain credit by being the ones that call other people out, whether it be on, I would say more often than not, on social media, with being the one that, catches someone saying something that's not politically correct, and then putting their professor on blast. And so we have this clear shift, maybe not so much in pharmacy, at least not that I've noticed from a student's perspective, but what seems to be very common in liberal arts colleges and universities within the social sciences, where students will hear something, even if it's just a metaphor. So an example that Jonathan Haidt gave is a professor would say something like, oh, if that happens to me, like, just kill me now. And they say that in passing without even thinking about it. And a student could hear that, and one option that they could do would be, if that truly offends them, maybe approach that professor in private and be like, hey, I know you didn't mean anything by this, but I think maybe that's a metaphor you should steer away from, with the implications of that joking about suicide. Like, I personally don't feel comfortable with that. That would be A-okay, and actually very encouraged if someone did feel uncomfortable to approach a professor like that. But instead, something that's seen a lot more commonly today would be for that student to hear that, to not consult the professor, and instead go on Twitter and put their professor on blast. And it looks not only bad for the university itself and the professor's reputation, but then the university now, if that tweet goes viral, now the university kind of feels pushed to crack down on that professor, because otherwise it's like, oh, now your university looks like they're too laissez-faire and letting professors do whatever they want. I don't know if you have experienced anything where you have to choose your wording more carefully in class over the last couple years.
Oh, yeah.
Because of like these societal shifts.
Oh, I mean, I think every year that I've been here, I've gradually kind of filtered a little bit more and more each year about, when I'm talking, to the point where sometimes I think, it does inhibit a little bit of humor that I might have had before, because I'm definitely afraid of that happening. And even if it doesn't go on social media, still to offend someone, it's so easy to do that these days.
Yeah.
But you're absolutely right that it can. That back when I was a new professor, there was, God, it was 12 years ago. But man, Facebook was just starting, I think. So even now, there's much more opportunity to get on social media and like I said, blast somebody. So yeah, it's something that it's almost like I don't even think about it. It's just an automatic being careful, filtering a lot of things that, like this example of just kill me now. I probably would have said something like that more often. Now it's like, okay, who's the audience? Yeah. Let's make sure I have people that are comfortable with that.
Yeah, and even if we have our pharmacy class size is usually 72 students, you could have 71 students in the room be totally fine and actually relate to you more by joking around to us. But if you have one single person in the room that is not willing to see little humorous things as just that humor and not to be taken explicitly and literally, but instead think like, okay, like I kind of wish you would have worded it differently, but that's just him explaining that thing, then they might do what we just talked about, putting that professor on blast, even if it's not on social media, doing something like, I'm going to take this to the head of the department.
Oh, sure, yeah, absolutely.
And it's so frustrating for me as a student looking in, just seeing very witty intellectual professors like yourself and other professors. You can kind of tell when if you're one of the students paying attention during lecture, you can tell that they're being selective with their word choice when they don't want to be. And I'm not encouraging any professors, of course, to be overtly...
That takes a very sharp, keen mind to be able for you to see that, because I kind of assumed that most students, or if not all of them, didn't really realize that was being done. But I certainly have to do that. So sometimes it's mid-sentence, though, and that's when you definitely would see it, like, oh, he wasn't going to say that, but he had to say that. He felt like he felt uncomfortable to say what he was going to say. Yeah. So yeah, you're absolutely right, and I'm glad you're aware of that. Like you said, you have to actually pay attention to be aware of that, and that's the tough thing. We for professors that go into a classroom, sometimes there will be those students that they're not, they're on the phone or something like that, and I don't really have strict rules about that. And then you have that group of students that sometimes you feel like you're just teaching just for them because at least they're listening. You know? And part of that goes back to the idea that at least when I was a student, almost everything that we learned we had to write real time. We were writing, and now most of the notes, at least here, we provide them. So most students are probably I'm assuming they're thinking, well, I'll just look at it later because he's going to say it, and he's going to say what's in the notes, so I'll just look at it. The only problem with that is sometimes we do elaborate, even if it's not something we scripted or planned, elaborate on an idea or emphasize it because it's something that is more important for you to commit to memory, that kind of thing.
Yeah, that makes sense. And the reason that I bring that up isn't to discourage professors from being careful. I understand that, it's kind of just the game that you have to play, I would think, with where society kind of rests now. But at the same time, it's frustrating because I want people in academia just to be playing the truth-seeking game and not playing, can I get this person in trouble for saying something that they accidentally offended me. I guess it's just frustrating for me to see people not being totally uninhibited's not the right word, but presenting information how they truly want to present it, because it's the best way for students to conceptualize it, and instead choosing different words because they're afraid to offend someone. That's frustrating from me from the outside looking in.
It's good to know that. That's really insightful for me to know that from you. I mean, and I've definitely, when I first started here, I would, when I was being evaluated by other professors, I don't know how you could not be a little less humorous, a little more serious when you're being observed by other professors before you go up for tenure. So that's another thing too. So not only you have two layers of, so first being politically correct, second, making sure that you impress the person evaluating you, and that definitely doesn't lend very well to being natural and using humor to garner the interaction or engagement, students engaging you in the classroom.
Yeah, and it doesn't even have to just be humor. I guess it gets a little trickier, I'm sure, for, I would say, a psychology professor talking about disparities psychologically, maybe not even just disparities, but just psychological differences between different sexes and races and stuff like that. I can see why that would be a lot touchier. But that being said, even things I'll just pull the one off the top of my head, in anatomy and physiology, when we went into endocrine, we talked about for hormonal reasons, namely, women often have a higher percent body fat than men, and there was some discussion among my peers, trying to word this as professionally as possible, reflecting that they were upset that was brought up during class. And in my head, it was we shouldn't be changing the facts to accommodate to things that upset people. We also shouldn't be changing our wording to intentionally upset people. That's in no way what I want to see happen. But I guess I was just wondering if you could speak to that, as you kind of did, but speak to that idea of we shouldn't be afraid to put the facts out there.
I wish that what I said was kind of something that everyone would follow, but I know that's not going to be the case. But I even say this in my personal life, not just my professional life. The most important thing to me is truth, like you said, being real. And if the reality is, and it is, and I'm glad it wasn't me who taught that, because I didn't teach endocrine, but I know who did, and the person who taught that I know would never mean anything negative by it. But
of course,
but having the reality, if body fat is higher because of in a certain sex, which it is in females on average, not everybody, but if you look at how low can a man go, how low can a male get his body fat? I think it's 5% to 3%. Women, it's almost impossible to get down to that low, and I'm sure it has to do with their hormones or their genetics, but what I think what it comes down to is that I don't know that people are always offended. I think people like to be on social media and act offended. And
of course, yeah. Which
I don't
goes
think
back into that call-out culture.
Right, if they couldn't promulgate this or distribute this so widely, would they really have an interest in being offended?
I agree, and that goes back to the call-out culture of you're getting that short-term reward of you're getting likes, you're getting retweets, I guess I'm just putting this in terms of Twitter, but that's a simple one that you often see things like that blow up, of people bashing other people, not just professors, but you get that short-term reward. And if there was no platform like, say, Twitter or Facebook to put that out there and get a bunch of likes and retweets, then you wouldn't have to be constantly seeking out things to put people on blast for.
Yeah, that we've come to a very significant problem with our this technology and social media, that people are getting rewarded for something that doesn't contribute to society.
Yeah.
And for example, the financial reward to producing a video that I've seen, some younger children in my life, in my household, watching a video of another family living their lives, which is really nothing exciting. It's very boring. And that family is making millions of dollars on people watching their life, which is not an extraordinary life.
Yeah.
They're going shopping. They're doing nothing, So, and they're being rewarded financially for they're not curing disease. They're not helping poverty, unless they're philanthropic, right? But that's not really the direct effect there. They're not really doing anything that's directly contributing, and I don't know the answer, how to fix it, because it's a kind of, the momentum is there. It's too late. Almost. So someone might have a fix, but I don't know what that is.
I agree. So that's one thing I thought of with academia, and I don't want to portray this all negative, because as many people around me know, I'm very much in love with school in general, and if I could get myself trapped in academia as a student, maybe not as a professor personally, but then I would love to do that, and maybe I will with med school and stuff down the road.
There's such a thing as a professional student. I've been told you don't want to be a professional student, but I almost wanted to. I'm 40 years old, and I've thought, man, wouldn't that be cool to get my MD and become a surgeon or something like that?
Just keep learning.
Yeah, and I think it's something I could possibly do, but I probably won't, because I enjoy what I'm doing now, and financially it would be rewarding, but I think it's, at this point it's a little too late. Even if I could, and I've seen guys, I actually saw an MD on one of my pharmacy rotations when I was a student. He was probably 60 to 65 years old, and he said, I just signed up to go to pharmacy school. Like, you're an MD, So I guess, that is such a rare exception, but I think he realized the utility in knowing more about the medications. But that takes a very special person to have that ambition.
I agree.
And to be a perpetual student, I think we all can be now if we want to be, because of the resources that are available out there.
Yeah.
And that's why some people get insomnia, because they'd rather read more than sleep, and it's tough for some people like myself to say to yourself, well, at some point you're not going to retain enough, or to have a productive sleep is going to allow you to learn better and more the next day.
Yeah.
So some people like that, like myself, have to constantly remind ourselves of that.
Yeah, I agree completely. I'm very often, even beyond studying just for school, but just with podcasts and books that I want to read, trying to tack that on top of, the already necessary school studying that has to be done can get a little tricky. I guess another way that I wanted to go with things that I saw in academia that have been a little troubling to me since I was here, after adding that caveat that I don't think it's all bad, and I think it's mostly good. Another thing that I had happen to me was a couple instances that went a little like this, where I would get a question wrong on an exam, and I would bring up to that professor why the textbook or their notes that they provided me with proof that, by that excerpt alone, I was right, and they would agree with me and say, you are right based on either the notes I provided you with or the textbook, and I'm sorry about that. If enough other people think the same way, then I'll give you the points back. And I have a lot of problems with being told by someone, again, in academia, that should be valuing truth at the highest level, telling me that they agree that I'm correct based on information provided, but whether or not I get points is determined on how many other people believe it. Because I feel like one of the highest virtues in academia shouldn't be how many people think something is right. It's just, is it just right?
No, I absolutely agree with you. I've tried from the very beginning to be the type of professor that if someone has a logical argument and there's no reason why I can consider that argument wrong, then I'll give them the points. And it's not about, oh, they're a whiner. They're not a whiner. I mean, if they're just seeking the truth and they're expecting to be given credit for being right, then they should. Yeah, I agree. They should be given credit for being right. And they're, and sometimes, I don't know if some people think that it's kind of extra effort, or they don't want to. I don't know, and I haven't talked to anyone specifically, or I can't think of a specific. I probably have in the past, but a conversation where someone said, well, they didn't want to be a pushover, or I'm just guessing maybe that they thought they'd be a pushover, or they thought. I mean, I don't think it would be a burden to change someone's grade. I mean, it's very easy to do it with the technology that we have. So, I'm leaning towards they don't want to seem like they're too easy, and I don't.
Yeah.
And I'm a strong believer that pride and ego has zero role in a job of a professor. Zero role to have an ego or to be competing with a student to see who can fight stronger for something. And it's not about. This sounds bad. It's not about the student or me. It's about what is accurate, what's right, what's wrong, and if the student's right, based on what they said, then give them the points. If they're not, then don't. And some of them will be upset about that too. If but from actually my experience is if I give a rational reason, a good explanation why that their answer is wrong, I very seldom get an argument after that. So it's just a matter of just being real. And
yeah.
I don't know. I mean, to me, it's just normal to say, oh yeah, you're right. Here's the points. It's just natural. So I don't know. I don't know why that doesn't always happen.
Yeah, and I feel like that shows a lot. Being a student that has had you as my professor for a lot of classes, it's worth commending that you've always been like a truth seeker more than anything else. So
thank you
for that. Before we wrap this thing up, a question that I've been trying to ask more and more just of people that I consider high performers or experts in any area is, do you have any big movie, book, podcast, or documentary recommendations that you think have greatly impacted your life that just really stand out to you as like, I wish everyone would read this or watch this or listen to this?
Let me think. I can't think of anything off the cuff. I know that sounds really bad. It's very non-traditional, but most of my reading is very based on a specific goal. So let me think. I'm trying to think. There might be a good answer to that, though. Let me give. Yeah, go ahead. Sorry.
Yeah, I mean, if not, it's very much still a valid answer if you aren't, the most impactful reading you do isn't, say reading something for pleasure that stuck out for you, but instead all of your reading is, goal-oriented research reading.
All my reading is based on how do I learn how to be self-sufficient. I mean, it's all my reading, and it's not a single article or a single book. It's, finding as many resources as you can to become an expert at whatever you want to do. So for me, it's wiring my house or fixing a car or anything. Anything, just being confident that if you've, for me, like if you got in your PharmD and your PhD, maybe you're capable of doing these other things on your own rather than hiring someone constantly to do everything, doing your own plumbing and stuff like that, and learning a new technique in the lab that you don't necessarily go somewhere else to learn. You kind of just read about it. But a book that someone gave me recently was called Strengths-Based Leadership, and I've been kind of toying with the idea of maybe becoming a chairperson later down the line, or a leader while continuing to do my research. And I thought that was a pretty good book. And that was actually our dean that gave that book, Strengths-Based Leadership. And the thing I liked about the book is there's so many books that give you advice, but that has a tool, a website that interviews you, or you do a survey and it tells you what kind of leadership that you migrate towards that you should be considering. And I also like the book because it gets away from what some leaders try to do, and that's trying to become good at everything. And it pushes you more towards capitalizing on what you're naturally good at and utilizing your team based on what they're naturally good at, right? And focusing more on bolstering their natural strengths without completely ignoring their weaknesses.
Yeah, I feel like that's a common entrepreneurial claim, is instead of focusing on only bringing your weaknesses up to par with your strengths, just triple down on your strengths, and as time allots, you can go back and make sure your weaknesses aren't totally holding you back. But for the most part, I feel like that makes sense what you're saying. Some people, me included, maybe focus a little too much on bringing the weaknesses up, whereas if you just triple down on your strengths, good things will come to fruition.
Yeah, here's my, but the reality is, so I like that book, but I in no way use it as a Bible or subscribe completely to anything like that, because I think people need to have faith in their own ideas, and when someone becomes, their life is completely led by what someone else said, they're not being creative enough. So I think a lot of it should be thinking of your own, thinking up your own solutions to keep your mind, agile and keep your synapses firing, rather than saying, this expert said this, let's try this. Because then the next thing you know, you're just a pawn to whatever the popular opinion is that year in that book, right? And you're going to change, and you need to become who you're really meant to be, and a lot of that's through your own thinking, your own self-reflection, rather than what did so and so say that we should be doing. That's just my opinion.
Yeah, I mean,
I can't prove that that's the right approach, but
it sounds like the right approach. Something just to kind of chime in that you kind of reminded me of. I feel like a lot of successful people, at least who I think embody success, one of the reasons that they're successful is often because they can hold conflicting ideas in their head, or dichotomous ideas in their head, and know when to weigh which ones. So it's not just hearing one person's idea, this is the way you do it, but to take multiple valid ideas from or different schools of thought from people you look up to, and in a situation know when to weight which one, and know when to turn to which idea, and know which ones will serve you best in a situation.
Absolutely.
But yeah, any shameless plugs you want to give where people can find you, or anything like that?
Well, if anyone wants to fall asleep, now I always say this in class, but I think it was fun for me to produce if anyone's interested in gastric acid. Oh my God! So that's not even my research area, but I made an image that I put on Wikipedia for gastric acid secretion.
I love that this is the first thing.
I don't know why that popped up. I just came out of nowhere. Something more important, I think, is that we did, and this is definitely a shameless plug, but it's definitely a plug, that we just started our master's degree. Mm-hmm. in pharmacology and medicinal chemistry at Wilkes University in the pharmacy school, and we're just starting to enroll students in our master's program for next fall. And I just want to say that there are so many jobs right now in the areas that we'll be training students in, and that's developing cell lines, doing chromatography, or ultra high performance liquid chromatography, and using a lot of this biotechnology stuff. So genetically engineering cells, studying cancer cells, using animal models. I just checked on Indeed, and there was, just for knowing how to grow cells, like cell culture, mammalian cells, about 360 jobs within 100 miles. Just for that, and that's usually a master's or bachelor's degree, but ours is a master's program. So I just want to say that a lot of people might not have heard of us if you're outside of this state, but you might have heard of our pharmacy school, but now part of that is our master's program, which is actually for a different set of students. PharmDs can probably do it, but it's designed for a separate set of students.
Awesome.
So thank you for giving me that opportunity.
Yeah.
By the way, we didn't plan on me saying anything about that.
Yeah, well, I mean, I always want to give people an opportunity to put anything out there that they're trying to get more
actually, this is the first
publicity on?
First time I've ever had a student ask me to do this kind of interview, so I think it was really, really fun, and I appreciate it.
Yeah, of course. Hopefully we can do it again someday.
Absolutely. Yeah,
All right.
I want to see what other professors you can get on.
Yeah, me too. I'm
Okay.
hoping I can rack some other ones up. But all right, call that a podcast. I think that's a good one.
Awesome.
Thank you, everyone. See ya. All right, everyone. Thank you all for tuning in. Please track us down on social media. Our Facebook is Insights of All Trades. Our Instagram is @InsightsOfAllTrades. Our Twitter is @IOAT Podcast. And you can find us on Gmail. It is insightsofalltrades@gmail.com. So please just send us in your insights. It would mean a lot to us and a lot to everyone else. Meaning, send in any tips or tricks you've learned through your trade or your passion that you think everyone would benefit from knowing. So until next time, adios.